uh, or sorry for those who are watching asynchronously. Uh, Welcome to the TriNetX Summer Bootcamp 2025, Week 2, Defining and Exploring Cohorts. As always, I'm Daniel Novak, Director of Student Scholarly Activities here at the School of Medicine at UCR. And I am running this so that I can help folks learn to use TriNetX more effectively. There, in fact, was even just an article yesterday in Science about how a number of different paper mills are actually using TriNetX to pump out really poor quality studies. So this is just my little part in trying to correct that. I think TriNetX is an incredible tool. I don't own any shares. They don't give me anything for saying that. I just really like using it with folks. And I think it's an incredible opportunity to help improve our physician scientist workforce. And hopefully after watching these videos, you'll learn a little bit about that. As always, I'm monitoring the chat. If you have any questions that I can answer directly, if you have anything you want to talk to me personally about, please let me know, and I'll give my booking link at the end as well. I'm a person. I do a lot of work. I also have, family life and all that kind of stuff as well. But, this is kind of the relevant stuff. I've done a lot of work over the years. My background is, as I mentioned before, is in learning sciences, an area that's kind of think of it as like the social psychology of education. And I've been doing this a long time. And I'm particularly proud to be working with medical students now. In the big picture of things, here we are in the week 2 of the 6 weeks that I put together for this. Last week we added an extra week, week 5, in order to talk some more about other kinds of tools that are valuable for people. And I think this is parsimonious, and I don't know if it's like binge-worthy TV to watch these sessions, but they are, I think, pretty much what you need to know. As I mentioned before, you're going to learn to navigate TriNetX, identify worthwhile projects, compare outcomes between patient cohorts, and use propensity score matching to reduce confounders. But today, specifically, we're going to talk about advanced cohort definition features to more clearly target your group of interest. We're going to adjust for temporal issues in your study. One thing I'm going to come back to again and again is time. Time is a crucial relationship in your studies, and you need to really consider it carefully, how it impacts the course of disease, how it impacts the findings that you're reporting. We're also going to look at examining your cohorts for additional confounding factors and inclusion and exclusion criteria, and develop a cohort construction diagram. Advanced cohort definition, exploring cohorts. Those are our topics for today. So looking back at the process, remember last time I had that really clunky metaphor for foundations and houses. So this week, we're still working in our foundations of our study, foundations of our analysis with term groups and exploring cohorts. That's week 2. And next week, we're going to move on to the house, the analysis itself. If you're following along in the rapid development process, you can see we're here in your build your cohorts section right there at that intersection. The blue one is very important. And if you're following the even more rapid process, you're going to be somewhere in the pull out key features, ICD-10 codes and CPT codes from an article, reconstructing that study in TriNetX, and refocusing the structure on your topic and cohort. You're going to need to know how to use all of these features in TriNetX to do that effectively. As again, earlier, we're in that foundation supporting the validity of your studies section, and we're going to be building the house next week. Here we go. If you read just one book, I'll bring this up, I think, several more times. If you just read one book on clinical epidemiology and clinical research, I recommend this one. It's very short. I don't have my copy here. It's in my office. But it has a really good chapter on observational epidemiology and some of the challenges associated with these kinds of observational studies. And it has a highly critical perspective on things like propensity score matching and stuff like that. So it's very, very good, very well written, easy to follow, lots of pictures for those of us who like them. I'm going to return also back today a couple of times to our example study. Last time, you remember I talked about this Instagram clown, some guy who claims to be some sort of nutrition expert from the university or with a degree from the University of Vienna. Can't really confirm or deny that on the internet, but he certainly managed to get a lot of clicks for his claims that Alzheimer's disease is a physician-created disease caused by overprescription of statins, and that is why we have an explosion in Alzheimer's disease in the last 40 years or so. None of this makes any sense. However, I like to use this as an example to show that good ideas, or at least ideas for scientific studies, I don't know if it's a good idea, but certainly ideas for scientific studies can come from anywhere and give you any kind, you can develop any kind of study based on these things. Um, so my hypothesis that I developed, and as you are developing your TriNetX studies, you're really going to want to think about what are your hypotheses, right? A lot of times when I talk to students, a very common error people make is to say, well, I just want to see if there's an association between X and Y. Yeah, there is, right? If you have a big enough data set, everything is associated. That's one of the kind of problems with big data analyses, right? Having a hypothesis is a really crucial way to make sure that there is an identified relationship that you're trying to suss out. So when I talk to people, not doing having your hypotheses clearly stated at the outset really makes it hard to assess whether you're making any progress in answering your questions up front. So the way I kind of framed it was, while there is extensive literature on statins and Alzheimer's disease, there are a few solid gaps and solid answers and many gaps. Research related to confounding factors, comorbidities, and etiological theories. So how the relationship of different components affect the disease course. So my question was, to what degree do statins impact people's odds of developing Alzheimer's disease? Pretty straightforward, though there are better ways to frame that question. One thing you will hear me harp on if you ever take my course at UCR is research questions should be stated as a question. I know that's a little bit pedantic, but it's actually important for helping you stay in the inquisitive framework and not simply say, a lot of times students will frame things and say like, our research question is about the relationship between statins and Alzheimer's disease. That's not a research question. That's a topic area of interest. A research question is, to what degree does one thing impact another, right? So I want you all to think about that very carefully as you're composing these. We'll talk about someday, if you take my class as well, PICO and thinking really carefully about how you're relating different components of questions and why questions are so important. But for now, my null hypothesis is that statin use is not associated with any changes in likelihood of development of Alzheimer's disease. That is, these things are completely orthogonal to each other and there's no relationship. And my H sub 1, my first hypothesis is that statin use is associated with a lower likelihood of developing Alzheimer's disease. So I'm going to weigh in on the side, or my hypothesis is that based on the existing research, the observational studies that indicate a small but statistically significant impact um, should bear out in here versus the randomized controlled trials, which showed no difference between statin use and Alzheimer's disease. So I think we're going to find stuff that's more in line with the observational studies. So now that we have our question, we can start defining our cohorts. Accurately defined cohorts are essential to getting a reliable picture of the right people. So the validity and generalizability of your whole study comes from how well you can define your cohorts, right? That's why these tools we're going to talk about today are so important. And we're going to talk a little bit really quickly about research design. So what methods when we're using TriNetX, this is going to come back when you write your manuscript. Um, what are the methods that we're actually using here? Well, there's kind of four main, I think three main categories I'm going to call attention to. I don't know why I said four. Cross-sectional studies, cohort studies, and case control studies. You'll learn a lot about this in the if you read the book on clinical epidemiology. But let's define two important terms that we'll revisit again and again. First, a cohort is a group of individuals who are defined by a shared characteristic. That is an exposure, a diagnosis, a procedure, a medication, something going on that gives them a common characteristic. And cohorts are selected by when they start in that cohort. So that exposure, the day that they are given that medication, the day that they're diagnosed with that disease, that's the day that we call the index event, right? That's the first time that the person has met all of the inclusion criteria for your studies. Now, there could be multiple things like they have asthma and they may have had asthma for years, but the day they're given albuterol, that's the day that they enter our study because that's the day they're indexed, right? They're added to the big pool of things. You can imagine an index with all of the different rows of these people, right? Who are being added as they meet that inclusion criteria on that specific day. And we can define index events in any number of different ways, and we'll talk about that in TriNetX as well, because it's extremely important as a concept to understand. One thing about cohorts is we follow them through time to observe their outcome, and they're used to compare differences between exposed and unexposed groups is the most common thing, or groups who have one set of treatments and groups who have a different one. Coming back to index event, it's a specific point in time that marks the start of that follow-up for a cohort and the first day that all features of the cohort become true. It's often based on an event like a diagnosis, procedure, or medication. I'm repeating myself, but I find that that's sometimes useful too. It's used to anchor the timeline for measuring before and after effects or long-term outcomes, and it's critical for defining exposure windows, outcome periods, and matching logic. And later on, we will be talking about a core problem in observational epidemiology called immortal time bias. That is, where you set your index event in such a way as people enter your study, but because of when those index events can occur, there might be a while before the person enters and when they're actually exposed to something. Like they might be diagnosed with asthma, and then a couple of years later, they're given albuterol. Well, during that time, any number of things could have happened. They could have had all sorts of negative outcomes or all sorts of negative impacts that affect their health state. So this is really important to understand how these things work. And we'll come back to this concept again and again as we do our analysis. Um, so what's the difference between these different studies? This is the core understanding is index events. Help us understand there actually are a lot of different differences between case control studies, cross-sectional studies, and cohort studies. But case control studies essentially start out with people who currently all have a characteristic, like they all currently have been diagnosed with breast cancer. And they, from that event, right, that index event of a diagnosis of breast cancer, case control studies, I know I'm dating myself a little bit because my medical students have now started to get to a point where they don't remember the movie Back to the Future. But if you've seen the movie, it has a DeLorean, an old-timey 1980s car that can go back into the past, right? So case control studies, imagine our DeLorean going back to the year 1955, as in the first movie. Cross-sectional studies are that one point in time, though. It's just on the day that they were diagnosed with breast cancer, how are they different? How are different groups of people different based on medication, smoking history, whatever might be of interest to you? But cohort studies, they're the opposite. This is when Marty McFly in the Back to the Future movies, again, feels super old. This is when he goes to the year 2015, which is now in our past, ironically. But um, that is cohort futures start from the index date and look into the future. So case control starts from the index date and looks into the past. Cohort studies start from the index date and look into the future. Temporality winds up being really crucial. So again, cross-sectional studies observe a population at a single point in time to assess the prevalence of a condition, exposure, or characteristic. So in 2015, years after the passage of the Affordable Care Act, what were rates of chronic illness decline in African American populations, right? So at that time point, what was happening? Case control studies look backwards in time, again, as I mentioned. So how does someone with a condition, disease, characteristic, and a very similar group who do not have that characteristic, what's going on with them? So comparing older adults with hip fracture, right, those are the cases, to similar individuals without hip fractures, and examine prior use of semaglutide to see if there's an association. This is a big area of interest. Um, elderly populations about whether semaglutides or semaglutide and GLP-1s can cause this. So what we can do is look backwards from the people who have developed those fractures to see if there are differences in rates of use of semaglutide. You can have nested case controls where you compare a pair of subgroups within a cohort, for example, amongst defined cancer patients, for example. So cohort studies look, as I mentioned earlier, they look forward, Back to the Future too, right? It's a study design that follows one or more groups over time to compare the incidence of an outcome between those exposed to a factor and those not exposed. So do patients over 65 who receive statins have lower rates of Alzheimer's disease over a 5-year period compared to similar patients who did not receive statins? So we're starting with people who were 65 or over when the indexed event falls. They had been diagnosed with Alzheimer's disease at some point in the past, and over that 5 years had received a statin. What happens to them next? You can also do before-after studies, right? So people who had, what were rates before the existence or the addition of a medication, the introduction of a medication, and what happens after the introduction of that. So before and after studies are another common approach. Okay, so Thank you for your attention to the methodologies. That's actually stuff, by the way, if you're a medical student, that stuff's all going to show up on step one and in your biostats and epidemiology course in med school. So do not be surprised if you happen to see that again. And you may want to like really be able to understand it well enough to explain it to somebody else. That's kind of the litmus test for this. I want to take a step back though and look at last time we talked about the query builder, right? Which was the core tool in TriNetX that we use to identify groups of people that we want to analyze, right? I want to re-highlight for you guys the different networks that are available when you are at UCR and your account's been generated. You will be given access to the US network, the global network, and the UC collaborative network. The reason that I generally recommend people who are working in the US context to stick with the US networks is because other countries, frankly, have different healthcare systems with different backgrounds. They don't use racial designations and characteristics the same way we do. And it can just be very confusing, even though you get a bigger pool of people in some of the global network. I generally recommend using the US network for most of our work, though there are some exceptions where that may be useful. The box there, that's our term search. That's where we can put in questions, or sorry, not questions, but statements, terms that we want to use to find people with particular characteristics. And our cohort definitions are are formed by the addition of these terms and their relationship in time. And there's that blue button up at the top. They may have changed it, I believe, to a, let me just see really quick. Uh, I believe they've changed the specific icon from a blue circle that spins to a thing that says count patients. So just make sure I'm giving you the right information here. Yeah, oh, sorry. It is the blue icon that spins. You'll see it right here. This will, hitting this button will um, cause your a new cohort to be formed over here. We'll talk about that in a moment. But also, it'll cause your numbers to get updated here in the event that there are some changes in the network population. That's one thing you should be aware of as you're using TriNetX is the data are refreshed frequently, which is great because then we always have the most up-to-date data. But there can be fluctuations in what systems are reporting data on any given day. So your numbers can change every time you rerun the variables. That's just a part of using real world data. It's like the ocean. The water can be different every single day. We'll talk about query cards in a moment. These are the cohorts that you're going to use to compare people later on. So let's actually jump into a little bit of this definition. You'll see in your TriNetX view, if you're using the traditional view over here, that is not the AI view, you'll see this whole row of all of these different little cards, and they are added every single time you hit the compare or the count patients button with a new set of terms in there. So what you'll see with these is each of these cohorts represents query cards represents a cohort that you can analyze using the analyze tools, the analysis tools that we're going to look at next time. And it does track the number of patients, healthcare organizations, and networks that were online on that day that you ran that study. So the day that I ran this, 63 of 64 healthcare organizations were online. You can see today that 69 of 70 are online. So you can see that there's a bigger pool of people available now than there were. I strongly recommend developing a naming convention for yourself. You can kind of see over here. I use this kind of like asthma by GLP-1 by no tuberculosis, like with the little X here to help remember them. And you can also add notes to yourself in these query notes tools to help you remember what's going on. Because as you go through this, anytime you make a change, you'll get a new card, and you may just find yourself getting confused over time about what exactly this cohort is. And it's really important to do version control very carefully as you will generate a lot of these. Let's talk about term groups though. So we're looking at query cards here. This is something that creates a lot of confusion for people, but it's something that wrapping your mind around early is very, very valuable about. So let's talk about the difference between cohorts and groups. So term groups help us to specify relationships within our cohorts by grouping terms, that is, specific features of a person's health record together in useful ways. So you can group terms in really four ways. Number of instances of a specific event. So if, for example, you want to look for people who have had um, four surgeries on their foot, at least four surgeries in their record, you can use a group to identify that. And I'll show you how in just a moment. You can look at the number of unique instances of the term in a group. So, for example, you could put in five risk factors and say, I want to see people with three of five risk factors or three of four risk factors in my pool. So you can have both the number of times that have appeared in there and the number of unique times that it's appeared in a person's record. You can also use related groups. This is how we set up temporal relationships. For example, a diagnosis of um, type 2 diabetes or an A1C over 6.5. And after that, the person was given semaglutide as opposed to being given semaglutide previously for some other reason, right? Um, or, for example, that they were diagnosed with cancer and then a surgery was performed, and then that surgery is different from some other event that would have required that surgery. So, you can also specify time constraints. Within 6 months, you can do it relative to now, or you can do things like during the COVID years from, let's say, March 13th, 2020 to March 13th, 2022. How were things different then than in the future? Lots and lots and lots of different ways to use these tools in different combinations. So let's go through them. Oops. Ooh, a little more carefully. Um, we just got the speed run on our study here on our presentation. All right. So to create a new term group, you're going to select the create a new group button at the bottom of the query screen, and you can create multiple groups and use and or. These are Boolean operators that let you specify relationships. So a person was on a statin or on a non-statin cholesterol medication, right? So you could set this up in a way. So let me just show you how this works. In this case, I have just a couple of nonsense things in here, but this might be useful to set it up. So what we're going to do is create a new term group using that button down here that I mentioned a moment ago. And we're going to add asthma. We're going to specify that the person had asthma and an A1C over 6.5 at the start of our study. And we're going to add in this case, related group that's going to allow us to see after that diagnosis of asthma and the day that they were diagnosed with both asthma and an A1C over 6.5, we want that to be the first time that they show up with semaglutide in their record. And we also want them to make sure that they never had never in any time in the past had tuberculosis. So what's going on here exactly? Let me set up a couple of things and then I'll be able to explain really quickly. This is our illness profile, right? And this is our medication. So when we set this up, this tool here allows us to set up relationships between this illness profile, 1A, and this medication, 1B in time. And what we're saying at 1A, that's the index event here. You can see they even say the same day. This is the first day that our study starts. We can go back into the past and specify that they'd never had semaglutide in the past, or we can look forward into the future, anytime after, and specify that their first instance of semaglutide occurred after the first day that they were diagnosed with asthma. You can use these. There's any instance, most recent instance, and first instance allow you to get a little more control over when these things pop up in the record. But let me just show you what happens next. Once you've named your profiles, you will see that it'll tell you in plain English that your cohort is going to include the people where the first instance of the medication, the semaglutide, occurred at least one day after any instance of illness profile that we have here. This kind of helps explain in plain English how these things are related in time. So now if you go back up and hit your count patients button, it'll now go and pull us the 99,510 people who meet this specific health profile. Okay, so that's kind of the general way that a new term group can help you out with stuff. It's all people, in this case, in this version that I'm showing you in this slide, it was all people who have statins and have comorbidities, right? Or in this case, um, this is actually important to know. If you don't include things in a term group, like for example, if we put things up here like tuberculosis, it will apply to everybody irrespective of time. That means that they could have developed tuberculosis after these events transpire, that they had asthma, high A1C, and semaglutide. They might have developed tuberculosis later or earlier. Unless you specify, you really can't know when tuberculosis occurred in this situation. The way to fix that is to use this little copy group button over here, and you can paste your groups here. And we're going to do a little surgery on our groups. We're going to add tuberculosis into our study, and we're going to specify that the presence of tuberculosis had to have occurred prior, at least one day prior, to developing asthma and having a high A1C. This is nonsense. I'm not really sure what this study would be, but this is just to give you a sense of how this works. So this is asthma times A1C, and here's your tuberculosis. So the first instance of tuberculosis occurred at least one day, right, before any instance of A1C. So what we've done here is now define our cohort, the entire group of all people in here, all of our study, as having had asthma and then A1C, and going forward into the future after that, they were given semaglutide, and they had previously, before being diagnosed with asthma and A1C, had tuberculosis. I actually have no idea how many people fit this characteristic, but let's just run it and see. It's 262 people fit this particular bill. So you can see by adding tuberculosis as a required characteristic before asthma and A1C, we actually wind up with a very small pool of people. But we can see what happens where the first instance of tuberculosis maybe occurs after their A1C. And you'll see that that time relationship is going to change those things. So, got a question in the chat. So we'll take a look at your question in just a couple minutes. When we get to a little bit of a break, but you can see here that developing tuberculosis afterwards, after these events become true, gives you a small count just as well, right? 176 people who have that feature in their record. So this is just to give you a little bit of a sense of what's going on. As I said earlier, though, you can also specify that these groups not be combined, that you have people with asthma and hemoglobin or an HbA1c above 6.5 and semaglutide, or that they have, I'm sorry, and an A1c over 6.5 and semaglutide, or that they have tuberculosis. So this will actually add together those groups of people into one cohort. So you can look and see what's going on with those groups. So you can see it's additive as opposed to, so we actually wind up with more people than our first version. So this is just a little bit about how that interface works. Of course, it's a little complex using these Boolean logic. It can actually give you a lot of flexibility to determine how these different factors in your studies are related to each other. And it can give you a lot of flexibility in terms of defining what occurred in the person's health span before they were included in your study. Let's go back. I want to start with a little bit. I'm going to blow up some of my cohorts here. I'm going to delete this group. You can select the delete all terms in group, and when you delete them, they all just disappear. And in this case, I'm going to hit this, and I'm just going to ungroup all the terms and delete my group. So now we've got a bunch of random terms, unrelated in time, no meaningful. We don't know whether the person had asthma first, then developed hemoglobin, or then developed high A1C, and then wasn't put on semaglutide, or they had asthma and then semaglutide, and then A1C or A1C, then some, it could be any of those combinations. We're going to look at a couple other ways. So we've looked at how to group them using related groups in time, but we're going to look at, as I mentioned earlier, how to create specific numbers of instances in the group. So we're going to, in this case, look for people again who meet this characteristic of having high A1C and asthma, and we're going to look and see how many times we want to make sure that they've been prescribed semaglutide. They've been given at least two prescriptions for it in their health record, or you can set up a whole bunch of different things. You can have like, between two and three, if that's some meaningful magical number in there, two and three doses of an antibiotic or two or three prescriptions for an antibiotic. Less than three or greater than three or exactly three, depending on what fits your study. So you can use this. When you do that, it will make sure that this person has exactly three instances of semaglutide in here. This is actually useful. One reason that this can be useful is, cystic fibrosis. This is a classic example in TriNetX. In the cystic fibrosis registry of all people, who volunteer to be included in it when they're born and diagnosed with cystic fibrosis, there are actually not even there aren't even 50,000 people in there. So we actually have some duplicate people in TriNetX, or people who were maybe diagnosed with cystic fibrosis because of salty sweat or mucus or coughing or something like that. And that was added to their health record, either, you know, too quickly or by mistake. But if you actually go back and set this and say a patient must have at least two diagnoses of cystic fibrosis in their record, it actually comes much more in line with what's known in the existing research about the prevalence of cystic fibrosis nationally. So this tool can help you, especially if you're looking at specific diseases like Alzheimer's or something like that. Make sure that the person's been diagnosed in their health record at least twice. So you're not getting people who maybe have been diagnosed and then later on their diagnosis was revised and excluded from the study. So those are a couple ways you can use the number of instances. As I was telling you earlier, the number of unique terms is very useful if you are doing stuff. You can access this. I'm going to delete this group here. You can create that setup by saying add number of unique instances. So for example, if you wanted to we're looking for MACEs, major adverse cardiovascular events. We're going to look for heart failure. We're going to look for mortality, deceased, right? The person passed away. We're going to look for stroke, infarction, right? Let's start with those. So, you might say in your study that we want to see people with at least two major adverse cardiovascular events before they enter our study. So generally, maybe deceased is not a great choice because it's kind of the last thing that happens to them. So you might not want to include that in there, but you might want to go back and include heart attack, infarction, myocardial infarction as well, in addition to, oops, you can see it's I-21 versus I-50, which is heart failure, and then infarction is I-63. I is all of the includes all of the various cerebrovascular diseases, so hemorrhages, things like that you might find. But in this case, we're going to say we want people to have at least two of these MACEs before they enter our study. So you can use this to help with identifying those individuals and making sure they have the correct number for your study. I already went over time constraints, but again, this is a different kind of time constraint. We went over related groups. Let me delete this and delete all the terms in the group. Oops. There we go. Delete all terms of group. We're gonna create a new group. And again, this is now number 4 in our list of stuff. I was actually just using this with someone today who wanted to know about drug shortages during COVID, right? They're doing a study on that, and they want to know whether during specific dates, this is actually most useful for specific dates, but during, the time frame of 03, 13, 2020, that's the day that they told us all to go home from work and work from home for an indeterminate amount of time, to 03, 13, 2022. Your study would run and only find people, for example, who were prescribed semaglutide during this time frame. You can also have it set with a relative time, for example, 5 years back from today, if that's something you want to do. But I generally find it's better to use specific dates because somebody reading your manuscript years in the future will be able to, in the year 2030, will be able to go back and say, will go back and be able to set this much more accurately than 5 years from today. So using specific dates can be more practical for our purposes. This is again useful for things like COVID, but also we've had a number of students do really interesting projects using comparison timeframes before the emergence of a particular drug or after one group of students used the passage of the Dobbs decision, or sorry, the implementation of the Dobbs decision on abortion to look at rates of surgical and pharmaceutical abortions throughout the United States, which was a really, really useful thing. One thing, though, you do have to remember in TriNetX is all of the data in TriNetX is date shifted, meaning that they add some amount of time to all of their service dates before they import it in order to protect people's dates of service, which is one of the HIPAA characteristics. So you may find that if you have really something specific that needs to be done on analysis on a particular day, that TriNetX is going to make it really hard to do that because the specific date may be shifted. Each health system shifts its dates in different ways to protect their patients. So you may or may not be able to get a precise date in there. So for the example for Dobbs, there's some flexibility in there because after that specific date, there were several weeks of uncertainty from different health systems and nobody did anything. So that means that there's a little bit of time, that a little bit of slush time in service dates didn't make a difference, but it can make a difference in your study as well. All right, time constraints. We already talked about related groups. This is probably the most important feature for you to understand in your cohort construction because the temporal relationships that you can define with this are going to be essential for making sure that your analyses are valid later. So I'm happy to revisit this a little later to discuss as well. So yeah, let me just show you this. This was a worked example. If we zoom in here on a more complex group, right? We have people who we use ibuprofen or aspirin as our index event, right? In this case, because it's not really that related to Alzheimer's disease, which was kind of the subject of this, but we wanted to exclude. You can see all of the different kinds of exclusion criteria. At the start of this study, we didn't want anybody to have epilepsy, hyperlipidemia, pure hypercholesteremia, psychosis related to substance like LSD or something like that, hypertension. We wanted to exclude vascular dementia, everything that might be a confounder for our study. And you can see here we're including all of the statins must have been prescribed at least within 5 years prior to that. So 1A contains all of our inclusion and exclusion criteria, and 1B includes our statins and that temporal relationship to 1A. So again, as I mentioned a few minutes ago, when you are using these tools to set temporal relationships, use this little function here by naming your cohorts, like your 1A, say placebo index event, or 1B first statin within 5 years. It actually can help you say it out loud, and that will help you check your logic. So this group includes everyone who ever had an aspirin or ibuprofen but did not have any of our comorbidities and had their first instance of the statin within 5 years before the ibuprofen or aspirin. And then you can see here it says the first instance of first statin within 5 years occurred within 5 years on or before any instance of placebo index event. So by saying this out loud, you can help to make sure that you're interpreting things correctly. I'm also going to introduce you to the idea as you're developing your cohorts of the stepwise approach to related groups. Related groups, again, super powerful function. You can only create, though, one related group between two things. So you'll see here, if we want to add that related group, that time relationship between two factors, you can't add a 1C to say they had semaglutide and A1C, and then after they had semaglutide and A1C, then they had asthma or something like that. You can't add a third function. So you kind of, the idea here is that actually the computation on that becomes progressively more complex. So let's say we want to create that relationship. Our semaglutide is prescribed after our A1C during, I'm going to take this out because during COVID, it wasn't, you wouldn't have seen a lot of use of that. But what we're going to do here is we're going to create an additional, using the Boolean logic, we're going to copy our stuff and we're going to set our starting point for this next group as the day that people had both a high A1C and semaglutide. And we're going to say that prior to that event, they had been diagnosed with asthma. So we're going to use what we had from before, and we're going to say that at least one day prior. Now, why at least one day? Well, sometimes people show up for, let's say, getting their blood sugar checked on here, but they're also diagnosed with asthma on the same day, which really wasn't what we're looking for. We want to know that prior to showing up for semaglutide, to get semaglutide and have their blood sugar checked, they had been diagnosed with asthma. So the first instance of asthma occurred sometime in the past prior to the prescription of these medications. So we're going to say A1C and GLP, and we're going to call this asthma. So the first instance of asthma occurred at least one day and any time into the past, because it says any time before, or you could even say 5 years or anyways, anything like that. At least one day before any instance of A1C and GLP. So now we've set up a situation where they got semaglutide after getting hemoglobin A1C, but when those things are true, whatever the time relationship between these might be, we want to know that prior to that, they had been diagnosed with asthma. So you could even actually say, you could delete semaglutide here and say, okay, we're going to make sure that they'd been diagnosed with asthma prior to being diagnosed with a high A1C. And then you hit count patients. And now you're going to see using this Boolean operator down here, this AND function that you can see right here, it's going to collect us people where both of these events are present in their record. So this is called the stepwise approach because we are using bundling our factors and adding additional related groups as we go down to ensure that we have really specific related groups in time. And that really helps us to make sure that our 88,245 people that we have in this study are exactly the people that we want. So yeah, as I mentioned earlier, you can copy your group. You can also, if you don't really care, if you want to capture both people who were on semaglutide after being diagnosed with an A1C, but or they had been captured, they had asthma prior to being diagnosed with high A1C, you can use the or function here to do that. What you're going to find is that's going to pull a lot of people with a lot of diverse illnesses, so that may or may not actually advance your cause. So using the and or functions, you can see that cohort's 10 times larger than our and cohort because these are like two parallel groups of people who are being smushed into one group. They're people with asthma or on semaglutide, but not necessarily both. So I know this is a lot. Playing, and I wouldn't say playing, but like deliberately practicing this in a couple of different ways to help you figure out if you can replicate existing studies is a good way to use these tools and to understand whether you're implementing them correctly as you are working through studies. But just remember, groups means groups of terms that can be defined to combine cohorts. Groups does not mean groups of people. Groups of terms are relationships between events in a person's health records, not groups of specific people. Those groups of terms can then get you a cohort, which is the group of people, but it's more like an abstraction, right? It's an abstract, the group is an abstract description of terms that relate to actual people. Cohorts are groups of people defined by terms. So that's really the main thing to understand is that when we're talking about term groups, we're not talking about the actual people. We're talking about an abstract representation. When we're talking about cohorts, we're talking about the actual people represented by those term groups. And a query is your search, right? It's this approach here that produces those groups that then are developed into your cohorts. So I know a lot of jargon in here, but once you understand groups of terms and you understand cohorts, it allows you to develop a very, very strong study. And the reason, just to revisit why this is important, it's going to be very obvious next week, is people will make a very common mistake. Please don't do this. They're going to try to use, for example, to compare. If you don't watch the next video, for example, you're going to potentially make the mistake of trying to compare group one and group two in your analytics tools. But the problem is group one and group two are groups of terms that are being pulled into one cohort. Only cohorts can be compared to each other. So what you're going to find later on is you can compare these, right? Statins or all statins and Alzheimer's disease in your thing, but you can't compare these groups over here. You can only compare cohorts or look at cohorts. So groups of terms create a cohort. Cohorts of people can be compared. Yes, so somebody is asking, can you copy one cohort to make small changes to the group to then compare them? Yes, you absolutely can do that. And the place that this is very useful is, let's say we're going to go back to this cohort I created previously. It's not particularly useful, but you might want to say, okay, this is our asthma by A1C by semaglutide by I'm going to say GLP-1, save myself some typing. Now you can just move this over here, and this cohort here is going to stay just fine. It's already locked in. And when you go up here to hit count patients, it's going to give you a new cohort. That's going to be your we're going to call this your control, which is asthma by A1C by GLP. Sorry, by no GLP. You can go back down here and call this your, I usually mark it as XP for experimental, right? XP V1. And you can star this to save it, right? So you can find it later on when you come back to do your analyses. So this, as Clarissa asked in the chat, yes, you can come back to your cohorts later. You can even also, as you ask, copy your group and create a new cohort and paste that in. Let me just a term just to make this a little easier so we don't have to go through a lot of interface steps. I'm going to paste the logic here. I do want to note one thing as we're talking about term groups, but please note that you cannot add demographic terms like Black or African American or white to these functions. I'm going to ask if anybody has an idea as to why you can't add these factors down into groups with time relationships like this, or even into any term group. If you want to unmute or type it into the chat, you can go ahead. Okay, well,
For the time ones, you'll always be white or you'll always be African American, like the time
yep,
constraints.
bingo, right? These are immutable factors that don't change, right? Same with, for example, somebody who's been widowed, right? Generally, you can't add that in. I agree. Emmanuel, big brain right there for Clarissa. Good job. And you'll see this will prevent you from running your query, trying to add a demographic in there. Um, so please bear that in mind as you are working on your studies. Okay. I'm going to show you the next function in here that I think is very useful. This is called the explore cohort function. So a lot of times, this is really useful for a couple of reasons. The first is a lot of times people want to compare cohorts. They want to look between cohorts and see, did people on one medication have worse outcomes? Did they have more? This is very common. This happens a lot when people try to do studies that look at post-operative infections. I'm just going to tell you, post-operative infections are extremely rare. They're not extremely, extremely rare, but they don't happen as much as you'd think. They're not really a very good lodestar outcome because the health systems we're looking at focus on that as a metric to correct. So generally, you don't get a lot of people who get immediate postoperative infections. This is because they are given prophylactic antibiotics and post-surgical antibiotics. They are being monitored frequently by nursing staff. You can sometimes have it when they go home, they maybe tear a stitch or something happens and they get an infection and they might wind up with sepsis, or surgery resulted in an error that caused a perforation of a bowel, and then you get all sorts of infections and sepsis and stuff like that. But generally, these outcomes are not common. But one way you can know whether you're going to even wind up with enough people to run your analysis at the end is to use the Explore cohort. It's kind of a spoiler for your thing. So the Explore cohort, let's look back at our pretty big pool. Actually, I'm going to look at our asthma and semaglutide group. And you're going to see over here, if you're looking at the traditional TriNetX view, you're going to see the Explore cohort function right here. So if you remember last time I talked to you guys about doctors don't pay money late, your demographics, diagnoses, procedures, medications, and labs are all going to be visible to you in this cohort. So this allows you, instead of having to set up all of these different factors to see whether there's a whether people have higher rates of uh, post-surgical negative post-surgical outcomes, or anything else that you might be interested in, you can do a spoiler and look ahead and see whether whether this is a common factor in these groups. If only 20 people, 100 people out of 100,000 have that outcome, you're going to have to start thinking about why that might be the case, right? There might be something unusual about those people or unusual about that outcome that's going to affect some of the decisions you're going to have to make when we talk about your analysis next week. Or maybe you might have to rethink your project just because certain outcomes are really rare. So let's really quickly, I'll show you in the interface first in the live system, and then I'll take you through some of the details in a moment. But you're going to see your demographics first. So for example, if your question involves do men or women have higher rates of X or Y, well, you'll find out really quickly whether, in this case, for the asthma by A1C and GLP group, it's 69, almost 69% female versus 31% male. Um, that tells you pretty quickly that if you're interested in differences in sex, that might actually be an interesting comparison, or you might find out that there are differences between men and women in those outcomes, or males and females in those outcomes. You're going to hit that, by the way, that run button up top to look at that. As I mentioned earlier, doctors don't pay money late. You're going to check your demographics, diagnoses, procedures, medications, and labs. Here's your demographics. We're going to look at your diagnoses next. So what this does basically is show you the complete ICD-10 codes for your cohort. Sometimes it takes a sample depending on how large your cohort is, but you can look at diagnoses within 3 months of index, 6 months, 12 months, 24 months, or anytime. You can also group them by acute or chronic ones. So you can cut out, if you're not interested in acute things like, you know, a heart attack or something like that. If you're looking at chronic diseases, like I'm just going to throw COPD, then that would be something where using the chronic disease filter will just save you a lot of scrolling. Or in this case, you can just look at everything. You can use a couple of additional tools. You can remove the hierarchy, and this will just show you the top 10 diagnoses, excluding, in this case, Z codes. We'll talk about Z codes in just a sec. But you can see that in this group, obviously, as 100% of the group has asthma, 99% of this group has type 2 diabetes. Not surprisingly, because we define them as being people who have type 2 diabetes based on their A1C. But you can see they have hypertension at rates 89%. Overweight and obesity, obviously, because if they're on type 2 diabetes, that's going to be highly comorbid, and all sorts of other stuff going on, including sleep disorders, abnormalities of breathing, things like that. So these tools can be really, really helpful in sorting through stuff quickly and to help you figure out whether your study is going to be worth doing. You can also export this CSV file with every single code and its percentage of representation in your study to a CSV file so you can sort it, filter it, use it to create heat maps, which is really cool, and all sorts of other stuff that might be interesting for your cohort definitions. Um, so, hey, if your study is about hypertensive chronic kidney disease, well, look at this. About 20% of this cohort, 18,000 people, have that as one of their eventual outcomes anytime in the future after the start of your study. Well, that means you may have enough people in here to do a pretty strong analysis with 18,000 people, depending on, what else you're interested in and what you're looking at. You may find yourself being able to have a viable study if this is part of your outcome. Another function, though, that is useful is if you want to, for example, include essential. We did not include this as part of our study, but if you're like, oh, you know what? I want to make sure that everybody in my study, not just 89%, but 100% of the people in this study have essential hypertension, you can click on these terms and add them to your slate. So if we hit add to must have or cannot have, it will automatically create a new term in here that we can then add into our study just like this. You can say they have to have essential hypertension, asthma, and high A1C before we start our study. And then you can, go back and redefine, run the numbers again and make sure that these folks represent what you're just interested in. You can also use the procedures function in exactly the way I just described to look at the all codes, but also just the ICD-10 procedural codes, right? This is your medical and surgical procedure codes here. For example, follow anytime following their entry into our study, people have an insertion into their heart and great vessel. I'm going to guess that this involves uh, infusion devices, some sort of catheter or something like that. That's done for through their maybe their leg artery. You'd have to take a look and see what this is. You can also look at their CPT codes to see what surgical or medical or radiological procedures are most common. Again, cardiovascular procedures on veins and arteries are very this is just added. This is just injections, but arterial procedures, for example, yeah, catheterization and venous puncture. But you can also go and look and see, do these people go on to have um, different kinds of procedures for peripheral arterial disease or other stuff like that that might be of interest. So you can use these functions to really help you with that. And if you rerun the export, you can also export these to a CSV file for sorting. Here's the same deal with your doctors don't pay money late. You can use this to see. Obviously, we included blood glucose regulation agents, but looking at this, you might want to know what percentage, 67% of these folks are on insulin anytime thereafter, right? You might also want to look at whether people are on metformin, about 78% of people, which, hey, it makes sense, right? I think also on SGLT2 inhibitors, right? You might want to look at some of those. These are some very, very common frontline techniques. Like if they have kidney issues, they're not going to be on SGLT2s, but they might be on metformin because it's very, very well tolerated, extremely cheap, and has been around for decades. So people are given it often in low doses very early on to prevent. And it even has longevity impacts, all sorts of good stuff because it improves metabolism of and excludes metabolism of glucose. So you might use this tool to help you figure out what maybe you're missing. Maybe we should go and add metformin to our cannot have. So we can focus on that 22% of people who never had metformin and see what's interesting about them. That might help us focus on what's happening with those people where they have developed high A1C and their doctor skips metformin and goes straight to a GLP-1. One group of students did a study using that exact strategy. They excluded people on a whole range of different outcomes because they wanted to see what they called the Hollywood GLP-1 users. That is, people with otherwise healthy characteristics who are on GLP-1s, maybe for lose weight loss that's unrelated to their immediate health state, and they were able to do a little analysis on that. That was very interesting. So now we're looking at your labs. As you can see, TriNetX provides you with a range of these are the most common labs you can see up here, or you can look at all categorical labs. One thing I'll tell you is Loink is the general coding system for labs, and it's kind of a mess. There are some ways that it's categorized, but it's not as easy to navigate as some of the more structured coding systems like ICD-10, CPT, and the medications, the VA systems. So it can be harder to navigate. You can search for things, and you can check the common labs very easily. TriNetX, when you see this TriNetX curated note next to it, it means they've often selected. You can actually click on the lab and see, number one, what they're including in this, but also in this case, they're including the general Loink you can see, sorry, if you click that, it'll show you the included LOINC codes. There's three different tests that TriNetX is pulling together into one unified code, and you can see generally how these distribute, right? So um, at 1 sigma, this is generally the patient values are something like 139, and you can see out further into the into the deeper um, standard deviations that these numbers increase pretty substantially. So you can go in here and specify that they must have a value over 120, and you can add that directly to your study like that pretty easily. You can zoom in on these as well to get a little clearer value on that. So this works for all of them. Let's go take a look at our A1C because we know we included that as lab value. That's going to be a core part of our say. Look, it's highlighted in blue, waiting for us under endocrinology. And we can look at it and see, okay, so we've included people over 6.5. This is what our distribution looks like, right? So we're taking people to the right of the distribution, which is kind of what we want. You could even go back here and specify that you actually want 6.2 instead of that. And you can also specify whether you want it to be their most recent value in their record or ever. Did this person ever hit a value of 6.2 and then they got metformin and then their numbers went down, but their weight didn't go down or something like that. You can come up with all sorts of ways to use these functions to get really specific definitions of your cohorts. So those are your labs. There's information on genomics in here too, but it's relatively small. This will change. I believe there's a company called Regeneron that has bought a piece of TriNetX, and TriNetX is going to have access to their data in a couple of years. So you'll see more genetic information being incorporated into this platform. They just had an announcement about that recently, and I'm sure the TriNetX people have some information. Okay, I'm going to just, now that we've looked at it in the live interface, I'm going to jump back through these slides to review for you. Here are your diagnoses, right? This can be really useful for helping to make sure that down the line, people have the diagnosis that you're interested in so that when you do your analysis, it's worth doing. You can, as I said earlier, quickly add codes to the must have, can't have to improve your cohort. This is something actually now that I'm looking at this, I want to talk about. In your diagnosis, this is a very common problem I see is when people use the query builder, I'm going to actually jump back to the query builder for a second. They'll often look for things like, uh, uh, you know, type 2 diabetes. And they see, oh my gosh, look at all of these things I have to add. I got to add this one and this one and this one and this one and this one. And I'm just going to ask again, can somebody identify what's common to all of these? E11. Thank you very much, Cindy. That's accurate. These are all categorized under E11. So what happens is when you go, we'll see this in the TriNetX, their interface actually animates this very helpfully. If you select E11, you're going to select everything underneath automatically. However, you might say, look, I'm not actually interested in everything. I'm interested only in this subset of people who have been tagged by some systems, about 1.6 million people, about diabetes with neurological complications. I only want that. There could be other people with other type 2 diabetes, but I only want to zoom in on this group. I would say a safer bet would be to select everybody with type 2 diabetes then add the neurological complications that you're interested in. But I just want you to be aware that in this platform, if you select a parent code, even let's say once we get into um, diabetes with kidney complications over here, you're going to see that there's actually a sub code for that, right? So type 2 diabetes is the top level code. Then there's type 2 diabetes with kidney complications, and then type 2 diabetes with diabetic nephropathy. So if you select the kidney complications, it'll be diabetic chronic kidney disease, diabetic nephropathy, and other diabetic kidney complication. So selecting a top level code selects all codes below it. And you just need to be aware of that because there's no need if you're just looking for all patients with type 2 diabetes because you want to grab those 9 million people and include them in your study. There's no need to go and get each one of these individually. However, conversely, if you're interested in a very specific like issue that patients are facing, for example, circulatory complications, then go and select only that one. I'm going to add that one to our query. So I just wanted to make you aware of that because it is a very common error that I see in how people set up their studies. They have like 6,000 codes, but all of those codes in some cases are child codes from other larger codes that are part of their studies. So it's not really necessary, and it means you're going to have to do a lot more typing and a lot more bookkeeping later on in your study. As I mentioned, you can also export those diagnoses and all those things to Excel for output. You can see this is what it looks like. I mentioned that earlier. You can, when you export it, you'll get the date that this was exported to Excel, all diagnoses within any time, the number of patients that were queried at that time, the number of health systems that were hooked up to this, and then you'll find going all the way down through here, all of the different codes and subcodes that are included. And you can use Excel's filter and tools to do that. Again, your procedures, these are CPT and billing codes that are structured around specific billing procedures. These are a quick note on CPT codes and where they come from. These are maintained and developed by the American Medical Association, and using them requires a license that can be very expensive. So some health systems use ICD-10 PCS codes and HCPS codes, either globally or because they're using them because they're standardized. There's lots of different reasons health systems choose these ways of tracking their billing. But try to include both your ICD-10 and your ICD-10, sorry, PCS and CPT codes to try to include to capture as many health systems and as many of the patients as possible. Looking back again at your medications tab, they're grouped by type and use. Your labs, again, defaults to common labs, which can hide other labs of interest in specific bugs that you might be interested in, gonorrhea or something like that, which is having a big upsurge. You'd have to look for that under all categorical. You'd search for that using that. And again, your lab profiles are visible here, so you can report these in your manuscripts and studies. So that's the big picture on the cohort analysis. One thing I want to share with you is also the summary statistics tab. This can be really useful because sometimes people, studies or reviewers might want to know a little bit about your cohorts, right? And TriNetX will tell you about some of these groups really nicely in here, right? So, for example, it'll tell you how many total patient facts, that is, pieces of information about your 18,000 patients are in there, and something on the order of 181 million individual bits of information about these folks, with an average of about 9,000 pieces of information per person, and that most of these were collected between 2011 and 2026. So you can see length of patient record for your cohort if that's a question that people have. Another function that's really useful is depending on who's in your cohort and how many health systems are in it, you can see a little bit, while you can't run an analysis to compare groups, you can see by census region how many people are in each group. So you'll see here that 39% of your people in this study are coming from the South Atlantic region and about 9% from New England. And you know, you can see the percentage in the West. Some of this reflects the presence of academic medical centers. They tend to be clustered along the East Coast and in the Midwest, with fewer in the West and the Pacific and Mountain. But this does help you to get a sense of a little bit about what's going on in your cohort. So you can see the number of patients drawn from each group and their percentage by region. So if you're doing a study that involves geography, this is as much as TriNetX will give you. Just want to be clear about that. There's no other way to conduct this analysis in TriNetX. There's no additional data about geography that you can draw. Um, so really useful, as I noted, best we can do in geography right here. So I want to identify, please, if you have any questions, you can raise your hand, or this is a good moment because we're going to switch gears a little bit as we get towards the end of our night tonight. Please go ahead, put them in the chat. We can revisit these and try and get to some questions. Or you can raise your hand or unmute yourself before we move on.
I have a question.
Sure.
Do you mind clarifying why you suggest for us to select the top level code in our queries as opposed to a more specific code? Is it to increase our population size in our study? Do you mind clarifying that point, please?
Sure. Yeah, it depends on what you're trying to accomplish with your study, right? So let's look at chronic kidney disease. So CKD has, you can see right here, right? It's N18. But you can see in here that there's a lot of specific stages underneath that. So it depends. If your study is not differentiating between stages of chronic kidney disease, you can just pick that top level and you'll grab all of them, right? Whether it's unspecified, a lot of times health systems may not use some of those more specific characteristics. So selecting just that more specific one, N18, will not select your unspecified. So people who might be of interest to your study are not going to get entered. However, it might be instead that you are creating a study and you want to include stage one, two, and three in one cohort, and let me just erase this, stage four and five, an end stage in another cohort. So it really depends on what you want to do, whether you should select your top level cohort or whether you want to select more specific lower level cohorts in here. Does that help answer a little bit?
Yes, thank you.
Okay, great. Thank you for your question. If anybody else has questions, please feel free to let me know or put it in the chat. Um, yes, so somebody is asking, can you have for the cannot have category, can I create a subgroup? I'm just going to go back here and just load it up with all the cannot haves. And yeah, you could do that if you wanted, right? You could go and say, look, I'm just going to have um, all of these things, all of these be excluded, right? I want tuberculosis and these, I want to have it be a negative cohort. But you do need, in any TriNetX study, you cannot merely create a negative cohort. In fact, it won't let you run this if you try to create a cohort defined by an absence. Actually, you know what? It does let you do it, but when you go to run an analysis, it's going to not give you an index event. There's no way to know when these people enter because all we've done is define them as not having characteristics, right? Versus if we create an entry characteristics like this. So yes, you can create an exclusion criteria group if that's going to be beneficial to your study. And that will help, that can help manage and keep things together for you. So another just note really quick as you're creating cohorts, beware of unaccountably large cohorts, right? A cohort of 105 million people. Why might that be a problem? Does anybody want to just, if we got any epidemiologists in the crowd, why is a cohort of 105 million people potentially problematic? Like more is better, right? It's America. Bigger cohorts are better. Repeatability. Okay, so is it possible that we might have issues on replicability of these groups? Where else are we going to find a pool of 105 million people to compare against? Or how would we even know whether this is representative or not? Those are good questions to be critical of. And also true, by the way, that's a good answer. I'm not going to give you the only answer that there is in the universe, but my caution, and you should be skeptical of studies that have really large cohorts because um, this includes everybody and their mother, right? Every conceivable thing that could go on, like 105 million people. You've got a 12-year-old with this kind of condition, bronchitis, and you've got a 55-year-old potentially with cardiovascular diseases. You've got people with strokes. You got people with Down syndrome. You have all sorts of stuff going on in this big soup. And rather than creating a more generalizable and better answer to our question, we're introducing an enormous amount of chaos, enormous amount of variability. If you remember your stats classes where you learned about variance, right? Subjects within and subjects between. We're introducing an enormous amount of variance in the subjects between groups when we have large studies. So you might wind up with a statistically significant difference between groups, or you might not, or who knows, right? There's all sorts of stuff. So ill-defined cohorts tend to be very, very, very large. That isn't to say that there aren't places where large cohorts can help with certain kinds of answers, but you really, really don't want to just wind up with like 9 million people because 9 million is good, right? I do often hear students say things like, I just wanted to increase the size of my cohort, so I included a bunch of stuff. That's not a good idea. It's just going to water down your results, right? Imagine putting um, hot water in your coffee, right? It doesn't make the coffee stronger. It just dilutes the amount of signal and it adds noise to your signal, and that's not great. So I just want to relay that message again. Really quickly, this is a couple of new features I want to highlight that TriNetX has introduced. They've added an AI help bot. Not everybody's going to have access to this right away. I believe actually you might be able to see this. I'm going to turn this on because this is the traditional TriNetX interface. They made a couple of changes a little while ago. That's called Enable AI Navigation. You can switch back and forth by clicking on your little profile button and disabling AI navigation. But basically, this introduces two assistants that are going to be kind of useful. One is a TriNetX help tool that gives you information about different dimensions of using this platform. So, how do I set up events that happen before other events? Well, it'll give you instructions using imagine a small language model that will help you out with that. Right now, we have not at this moment turned this on for UCR folks. We're just getting soliciting IT's blessing and ideas first. But basically, there's an additional tool called in the AI field called AI TriNetX Design. And what this allows you to do is type in information like pregnancy, or in this case, I want to find people who have cesarean deliveries. So by typing in C-section, it helped me identify these codes that are going to be useful. So things that have a lot of different codes that tie into them: pregnancy, COVID, yeah, different types of cancers and different types of tests. Those can all be this can be a very useful tool for helping out with that. It won't specifically um, create those time and temporal relationships that we were talking about earlier, at least not yet, but it will help you find codes and include them as must have or cannot have much more quickly. So you can see it'll show up next to here, and you can enter your concept, identify the codes. TriNetX will identify the codes that match these concepts, and then you can use the Add to Query button to add those to your study. And that'll help make things go a little quicker. I'm going to switch back to the Disable AI navigation system for a little bit, just because I tend to find this a little easier to navigate. But, hey, whatever floats your boat. We're going to talk really quickly about building your counter cohort. So this is as much conceptual as it is um, about what you click, what buttons to click. If you're comparing outcomes for a group, like an experimental or control group, you can use your experimental group to quickly create your second cohort. This goes back to Cindy's question a moment ago, where, or sorry, sorry, Clarissa's question a moment ago about if you have a group that you've already defined and you want to, copy it and make changes to it. Yes, you can absolutely. This is part of how you might do that, right? For simple comparisons, you don't have to start again. You can just swap in your must have and cannot have, move around. For more complex comparisons, you may have to adjust your timelines and filters or other items. So again, I showed you earlier, you can use that copy button. Over here, there's a copy and a trash button that you can use to move things around. In this case, this is my cohort to that I used to identify people who had had ibuprofen or an aspirin, and then had statins prescribed versus people with ibuprofen and a stat or ibuprofen and aspirin who never received statins. So you can really easily, for example, by using the delete key on the delete button rather on these, you can ungroup your terms really quickly and get them up into your cannot have function. So it can help you make quicker work. That's just a workflow improvement. But what I really want you to think about when you're creating your counter cohort, I believe the chapter in the clinical epidemiology book is a cohort of what, right? Who is the comparison group in your study? Is it everybody with the medication versus everybody in the universe without? Well, the everybody without group can have a lot of variety. You can have a big cohort with a lot of noise in it that's not really actually relevant to your question of how effective a medication is, right? Think about which cohorts are going to be easier to build first, and then consider which one's going to be easier to convert into your group. But also make sure you're thinking about, is my group a good comparison? Um, I got ahead of myself. Here's the slide where I present some of that information. Whom are we comparing in your county cohort? A lot of projects start with cohort versus a big comparison population, all pregnant women versus with Huntington's disease versus all pregnant women without Huntington's disease is not a particularly useful description because the group with Huntington's disease is very, very specific and non-generalizable. It's not going to make you a good study out of here. You're going to want to look at them on their own terms. Seems natural, right, to compare everybody with something versus everybody without, but it can lead to those poor quality study results I was warning you about, since you'll have a lot of variance in your study. And the problem, again, of scale shows up because the cohort might have a few thousand patients, but the entire population might have several million. And unless you carefully control that, this can increase random bias or other kinds of non-random bias that might show up in your study. Therefore, I'm going to ask you to carefully consider your comparisons to ensure that you're not introducing variance to your comparison and that you're really comparing apples to apples, right? Groups that are meaningful comparisons. You could say, for example, people on metformin versus people with GLP-1s. Is one more likely to get Alzheimer's than the other? And what does that mean? Well, that's probably better than just everybody in the world versus people with GLP-1s. The people on metformin are probably more close in a lot of ways. So you're going to have to do less work to reduce random bias later on. Okay, we're in the home stretch today. I just want to return to our worked example before we close out and talk about refining your cohort with AI. Um, I like to use Perplexity to help quickly identify known comorbidities and confounders. It's not to say AI is without its flaws. Here we are 3, 4 years into the use of AI in society, and it is absolutely not without its problems. But Perplexity does do a nice job of helping you to get oriented into the literature. It is not a replacement for years of clinical expertise or research, but it can help you maximize your time with an expert by getting the basic stuff, drug names, informations, obvious procedures into your head. So when you're talking with, say, a physician who is mentoring your work, you already have identified the most common stuff, and you can really say like, okay, well, what's missing here? Based on your years of clinical expertise, what should I also include, or what do you commonly include in your hospital system that, an AI may not have been able to identify from existing research? I did this, but also I examined the existing research, and here are some of my exclusion criteria. There were 16, and I grouped these very deliberately. We're looking at, because this is looking back at Alzheimer's. Alzheimer's, there's a lot of different hypotheses as to how this disease unfolds. There's metabolic hypotheses, right? Type 1 diabetes, hyperlipidemia, right? A1C, all sorts of stuff. Hyperlipidemia is, however, why we give statins. So ultimately, we use that as our selection criteria. There's neurological hypotheses, right? Like, for example, vascular dementia may cause cascading series of different negative outcomes, or sleep disorders can cause negative outcomes that cause inflammation, which then lead to the buildup of prions in your brain, all sorts of stuff like that. Or sorry, the amyloid plaques in your brain. We have cardiovascular hypotheses that seem to go hand in hand, cardiometabolic stuff that goes hand in hand with this, as well as viral hypotheses. There's a number of different studies that have found that both HPV, prions, and the zoster, herpes zoster vaccine virus occur in are visible in the brain tissue of patients with Alzheimer's at very, very high rates compared to the average person. So we want to make sure that we're not just seeing the fact that people with HPV wind up maybe having a slightly elevated risk of Alzheimer's later on. We want to know what impact does this drug, this class of drugs, the statins, have on these outcomes. So we tried to exclude as much of this as possible. Ironically, we didn't include cancer because AI helpfully pointed this out. There are a number of studies that find that cancers are associated with an 11% reduction in Alzheimer's disease diagnoses. And cancer patients often have slower cognitive decline that aren't related to chemo, radiation, or cancer drugs. They're independent of that. So one possibility is that cancer cells, because their metabolic activity is messed up, consume glucose at higher rates, which causes lower rates of inflammatory insulin responses in the brain during key periods that might impact Alzheimer's disease. Or it could be genetic in some way that those folks are better able to process all sorts of stuff. So one thing you'll also identify is that your query builder can help you identify additional confounders that you might want to include in your counter cohort. So use the must-have, can't-have function to exclude things that, you might go, oh, you know what? I should exclude hypertensive chronic kidney disease because that goes along with a bunch of other stuff that I'm concerned about, or it might have a plausible biomedical reason that there's a relationship in these between that and my end outcome. So I'm going to delete that. So those are just some notes on creating your counter cohort so that what you're comparing your experimental or group of interest versus some group is an actual comparison that illuminates your hypothesis and doesn't just introduce a lot of random craziness from 20 million people being in your study. Big data does not necessarily mean better data, like bigger is not necessarily better. You want to think about what your cohorts mean. And in doing that, we're going to talk about creating your cohort diagrams. I 100%, 1 million billion percent recommend that you do this for every major study that you do, anything you're going to try to get published or get into a conference, because people are going to show up. And yes, you can verbally explain how your cohorts were set up, but a diagram like this, I actually pulled this from a study from Taiwan, can be extremely useful in explaining how your study was put together. And it provides a really clear and succinct map of relevant inclusion, exclusion, and cohort criteria. Yours doesn't have to look exactly like this, but I'll show you mine from our Alzheimer's study. You can see here's our manuscript. Ours looked something like this, right? And it really clearly and quickly allows you to see what exactly we wound up including, excluding, how our time relationships were set up, right? So 1 day following the diagnosis of disorders of lipoprotein metabolism and statin prescription, that's when our people entered our study. And you can see I even included our outcome and how many people were in those final diagnostic groups. It was actually a very small number of people ultimately who developed Alzheimer's because, obviously we're picking a very healthy cohort that does not have many of the comorbidities, because what we want to know is, do the statins, the drugs themselves, have an impact on Alzheimer's? Not, do people with all of these different comorbidities wind up having worse outcomes? So that's just something we want you to consider. And something that, because I would never ask you to do something but not help you out with it, we do include on our scholarly activities portal a template for creating these cohorts. You can click on this and add it to your Google Drive if you happen to have it. Just give me one sec. And when you have copied it to your Google Drive, you will be able to edit this and make it your own and change it and export it in high enough resolution that you'll be able to publish it. So please develop these as you go. We even have versions that include two different comparisons and up to three different comparisons. I'll give you an example of why this one is useful. Call this a three-chambered design. We had a student who compared an older omalizumab, which is an older drug that's used to treat asthma in more extreme cases. And as he was reading, the student, Raymond Jackson, he's a fourth year now, he found that one of the studies found that it had been superseded by a newer drug called dupilumab, and that omalizumab and dupilumab, the superior drug, was being prescribed at lower rates to Black patients compared to the inferior older drug, omalizumab. So we wanted to test this. This was just a footnote in a study that he read about these two asthma drugs, but we wanted to test this to find out, could we actually verify that this is true independently in a different data set? So yeah, we came up with this three-chamber design. The first chamber in this analysis, the first set of cohorts, was just to see whether people with asthma who get omalizumab or dupilumab wind up having higher or lower rates of acute respiratory distress or acute respiratory failure. It turns out, yes, the newer drug is better. We were able to verify that, so good for us, right? That means our data set generally comports with the existing research. Number two, we wanted to know, is there a discrepancy or disparity in the visible data that based on that study that found that there was a disparity in prescription practices for Black patients? Could we also see that? And yes, we were able to verify that white patients were being prescribed the newer, better drug, dupilumab, at higher rates than the Black patients. Okay, well, we want to know, does that cause harm, right? So in our third chamber, we compared Black patients who were given omalizumab versus dupilumab, and we found that, yes, in fact, patients with the newer drug had lower rates of Black patients with the newer drug had lower rates of acute respiratory distress than patients with the older drug. So chamber one, yes, we find that the new drug is better than the old drug, just like all the studies say. Chamber two, yes, white patients are getting the newer drug at higher rates than Black patients are in our pool. And chamber three, that's causing material harm. People are having more bouts or more issues of acute respiratory distress than they might have if they're given the newer drug. There could be many reasons why those drugs are being prescribed in disparate rates, but we do know that is leading to people having worse outcomes in that time frame. So this is the kind of model that you could use when you set up these multiple chambers, but you want to be crystal clear when you're communicating, because that's a very big claim to make, right? We had to be very careful. Raymond did a great job of developing that study, and you want to be able to communicate that as crystal clear as possible to potential folks. Another reason that these are really important is because of fluctuations on the TriNetX network, your numbers might change from one day to the next, right? Especially if you're working on really thin margins, like 500 people. You might find that some networks are offline for maintenance or changing or moving around or whatever, and you might find that your numbers change. So having one of these cohort diagrams can help you. Let's say somebody's reading your paper 5 years in the future. They might be looking at a much larger or smaller TriNetX network than you are looking at on this day. So including those numbers on the day that, the closest day that you can pin all this stuff down can be extremely valuable to your analysis and to the validity of your study and its long-term utility. Always use the numbers from the day that you ran your last version of your analysis that you're using for your write-up. Okay, thank you very much for your time today. I know we're a little over. I just want to give you a couple of notes on our practice problems from last week. And if you've got any questions, please put them in the chat as we are talking. I am almost done here. Last week, we talked about creating cohorts with a cohort of women between the ages of 18 to 45 who have had laparoscopic surgery and a diagnosis of fibroids. let's take a look really quickly at the platform to see how um, this is playing out, right? So we're going to look at um, we're going to first identify the demographics here. We're going to be looking for age and sex. Um, we are looking for people between 18 and 45, right? So we're going to start there. And we are not interested in male participants. Unknown, by the way, is not a political category necessarily. It just means they either don't have that information or the box wasn't checked. It does not mean necessarily transgender. So I generally would say don't include it because we want for our purposes of this study to include female participants, people who identify as female by sex. Um, we're going to include a diagnosis of fibroids, right? So first, the people are diagnosed with fibroids, right? And we're also going to look for laparoscopic surgeries. This is one where AI can help you out to identify, and I'm spelling laparoscopic terribly here because it's laparoscopic, right? There we go. Um, You can see laparoscopic, hysteroscopic procedures on the corpus uteri, right? Which might be what we're interested if we're looking at fibroids. We can also follow this using the tree that we talked about earlier, our little diagram, to see surgical procedures on the corpus uteri. So we can see all of the surgical procedures that are available, repair, introduction procedures, right, for different kinds of things that might be going on. But in this case, we want laparoscopic, and we can get a little more detail on these laparoscopic surgeries in here as well. So hysterectomies and other kinds of things. But in this case, we're just going to look at a laparoscopic surgery because we did not specifically define that. So let's take a look. Cohort of women between the ages of 18 and 45 who have had a laparoscopic surgery and diagnosis of fibroids. For our purposes right now, we have women 18 to 45, fibroids, laparoscopic surgery. Boom, ready to go. Very simple, right? I'm going to show you in a moment. We're going to add some complexity to this. I want to look at our other group, which is create a cohort of type 2 diabetic patients with a BMI over 30 who were treated with 5 milligrams of semaglutide but never received metformin or SGLT2s. So we're going to go back here. I'm actually going to create a new cohort because we don't really want to reuse that one. I'm going to be looking for people who are type 2 diabetes, and we want them to have a BMI over 30. So we're going to use the BMI lab value here, though there's a couple of other ways we can actually do this. You can see when I type in BMI, I want to see, it's going to give me the lab values, and I want to say a BMI greater than or equal to 30. You know, some people, even though 28 is technically the correct number, some people can be relatively healthy at slightly higher BMIs. You can go, in some cases, some people say maybe as high as 35 and not have necessarily problems. So we're going to say they have type 2 diabetes and a BMI over 32. And we're going to say that they were treated with 5 milligrams of semaglutide. And when we go in here, we're going to go hit this little term filter on our semaglutide to specify that we want 5 milligrams, which of course I picked a value that's not possible. We're going to pick 7 milligrams of semaglutide because that's a little closer. So now we've got that set up, and we also want to exclude people on metformin for some reason because we don't want to see the confounding components on that, and SGLT2 inhibitors. There we go. So pretty straightforward, right? This is the simple version of what I taught you last week. What we're going to be looking at going forward next week is a little bit more complex. We're going to add some, we're going to take those exact same ones. We're going to say a cohort of women between the ages of 18 and 45. And we want to specify that the diagnosis of fibroids occurred before the laparoscopic surgery, right? So now we're going to add a time dimension to this based on some of what we talked about. And similarly, we want to create that type 2 diabetic cohort with patients over BMI and specify that they were treated with, in this case, you can pick 7 milligrams of semaglutide, but never received metformin or SGLT2 before the GLP-1. So we're going to have to create an additional time relationship here before we do that. So um, that is it for today. Next time, we're going to be talking about comparing cohorts. This is the fun part where we get to see a little bit about how these cohorts are put together. And we will be getting deeper into TriNetX and its abilities. So with that, I'm going to stop our recording for today, and I am going to take some questions and answer some questions from folks here. So stop our recording.